Welcome to ADAA's educational webinar exploring the intersection of eating disorders and anxiety and depression, presented by Dr. David Alperovitz in collaboration with McLean Hospital. Dr. Alperovitz has over 30 years of experience working at McLean Hospital, primarily with individuals with OCD, eating disorders, trauma histories, and dissociative symptoms. He has maintained a private practice treating adolescents and adults for close to 25 years. He became the program director of the Klarman Eating Disorder Center in 2022 and is currently the director of training and psychological services at the OCD Institute at McLean Hospital. Welcome, Dr. Alperovitz.
So let's get started on this important topic. Today I'm going to talk about the intersection between eating disorders and anxiety and depression. And I should begin by mentioning how I became interested in treating eating disorders, as it's relevant to today's talk. My primary early career work was with adults struggling with severe anxiety and mood disorders, as well as PTSD. But I quickly began to learn that significant numbers of the patients I was seeing were presenting with coexisting eating disorders. And although I wasn't doing a whole lot to help them with their eating disorders, I became curious about their struggles. And this led me ultimately to working at the Klarman Eating Disorder Center at McLean Hospital. While at Klarman, working primarily with individuals with eating disorders, I noticed that almost all of them suffered from anxiety, and many struggled specifically with OCD. This emerging curiosity led me to working at the OCD Institute at McLean Hospital. So in essence, the intersection of depression and anxiety led me to working with eating disorders, and subsequently working with eating disorders led me back to working with anxiety and mood disorders. In my work today, I combine these interests, and the parallel processes around these important intersections will be what we explore in today's webinar. So today I'm mostly going to focus on anorexia and use it as an example around the intersections of depression and anxiety. But I will go over some of the other major, most common eating disorders as well. So leaving anorexia for subsequent slides, if we begin with bulimia nervosa, this is objectively recurring episodes of binge eating, with recurrent episodes of compensatory behaviors such as self-induced vomiting, a misuse of laxatives or diuretics, medications, fasting, or excessive exercise. And there's a self-evaluation that's unduly based on shape and weight with bulimia nervosa. Quickly, with binge eating disorder, which is the most prevalent of all eating disorders, impacting roughly 2 to 3% of the general population at some point across the lifespan. It consists of recurrent episodes of binge eating, and these binges are associated with one or more of the following: eating rapidly, eating until uncomfortably full, eating large amounts when not hungry, eating alone because embarrassed, and feeling disgusted or guilty. So there's marked distress when binge eating is present. And with binge eating, it's not associated with regular use of compensatory behaviors such as in bulimia. And finally, avoidant restrictive food intake disorder, or ARFID. Our newest diagnosis in the eating disorder field came in 2013. And it's characterized by an eating disturbance causing failure to meet appropriate nutritional needs with one or more of the following: either significant weight loss, significant nutritional deficiency, or a dependence on enteral feeding or oral nutritional supplements. It's not impacted by weight and shape or body image component, and it typically presents as one or more of the following: a lack of interest in food, avoidance of food based on the sensory characteristics of that food, or a concern about adverse consequences of eating, such as emetophobia or vomiting or contamination and fears. Before I move on to the intersection of eating disorders and anxiety and depression, I should say that many clinicians, myself included, consider eating disorders to be anxiety disorders. They are not classified as such in the DSM. They are classified under their own category titled feeding and eating disorders. Of note, though, the most common psychiatric disorders which co-occur with eating disorders are anxiety disorders, including obsessive compulsive disorder and social anxiety, and mood disorders, mainly major depression. We also see significant co-occurrence of post-traumatic stress disorder and trauma, and to a slightly lesser degree, but still significant, we often see coexisting substance use disorders as well as personality disorders. In my clinical experience, rarely does anyone fall neatly into a constructed box known as a diagnosis. More often, individuals will have symptoms that fall into several boxes, and often not fall very neatly into those as well. I find this to be especially true with eating disorders. Clearly, we know eating disorders are complex, and when there's a co-occurring disorder, diagnosis and treatment become even more complex. Now let's move on to explore how anorexia nervosa relates to and intersects with both anxiety and depression. In diagnosing an eating disorder, I believe we must use a biopsychosocial model and understand that the origins of an eating disorder are multifactorial. We must consider biological factors, such as genetics and family history. Similarly, we must evaluate psychological factors, including other mental health conditions and their correlation, personality traits, and behavioral risk factors. Lastly, we must also need to consider social factors related to the onset of eating disorders, such as childhood and social environment, the media, especially social media, and demographic factors. Now, I'm going to focus on anorexia to emphasize the intersection between eating disorders and depression and anxiety. And although there are differences in the presentation of all eating disorders, I do find that these intersections occur for all eating disorders around anxiety and depression. If we turn to anorexia nervosa particularly, it's defined as a restriction of food intake relative to the requirements leading to a significantly low body weight. It is accompanied with an intense fear of gaining weight or becoming fat, or persistent behaviors that interfere with weight gain. There's often a body image disturbance and an undue influence on body, weight, or shape on the self-evaluation, or a persistent lack of recognition of the seriousness of the illness. There are a couple of subtypes, both a restricting type and a binge-purge type. Now let's turn to see how anxiety and anorexia impact each other. And then in subsequent slides, we'll look at this same relationship with depression. This is what I call the vicious cycle of anxiety. Essentially, we have triggers which lead to thoughts and feelings, physical symptoms, and ultimately behaviors. If we look at anxiety in particular, a trigger is a specific situation. In this case, let's use the example of an exposure to social media, which might lead to unrealistic expectations around weight, body shape, or size, potentially body image distortion or dissatisfaction. This would lead to anxious thoughts, often catastrophic and worst-case scenario thinking, a significant fear of gaining weight. Now, the brain processes anxiety through the amygdala, which is the body's alarm center. And this is the brain region responsible for processing emotions and fear. When faced with a perceived threat, the amygdala activates into the fight or flight response in the body. And this leads to many physical symptoms, including racing heartbeat, palpitations, rapid breathing, muscle tension, sweating, and particularly relevant to eating disorders, issues around stomach discomfort, which leads to avoidance behavior. To cope with overwhelming feelings, a person avoids the situation, in this case food, via restriction, which temporarily reduces anxiety. However, it also reinforces the idea that weight or weight gain is dangerous. The consequences of malnourishment themselves lead to more rigid thinking, more black and white thinking, and more vulnerability to anxiety. Examples are less flexible perspective. And then what ensues is a new round of triggers, which include increased distorted body image, increased anxiety, or fear of weight gain. I think it's important that we think of this as an adaptive response, at least in its origins. It's one that may not be actually serving people in the present, but if we conceive of these mechanisms to protect ourselves, maybe from bullying, but ultimately if they're causing malnutrition, they're not serving us. In a similar vein, we are an adaptive species, and we can do quite well with low nourishment for a while. Our lab results and vital signs might even look good. People can do well at work and school and socially, but it takes more effort, and ultimately it's not sustainable, and things can fall apart very quickly. So while all these positive signs can be present, they're not necessarily signs that everything is okay, and they should not be trusted when someone's at a significantly or dangerously low weight. Now turning to a similar feedback loop, the vicious cycle between depression and anorexia. I should say that between 50 and 75% of those people living with an eating disorder, and this includes anorexia nervosa, bulimia nervosa, and binge eating disorder, experience symptoms of depression. Research points to a clear association between eating disorders and depression. A diagnosis of major depressive disorder with eating disorders has been associated with high rates of suicide attempts and suicide-related mortality. Eating disorders are among the deadliest mental illness, second only to opiate overdose. In this case, again, with initial triggers followed by behaviors and physical symptoms, we see another vicious cycle. How does depression fuel eating disorder behaviors? Well, several ways. First, emotional coping. Individuals may use food and eating behaviors to numb or escape from painful or depressive emotions like sadness, stress, and anxiety. For example, a person might binge eat to find temporary comfort or restrict to numb from the feelings. A need for control. A person who feels a loss of control in their life due to depression may resort to rigidly trying to control their food, their intake, their weight, or body shape to regain a sense of agency. Low motivation, also associated with depression, and can sap energy and make it harder to engage in healthy self-care and eating habits, which of course can worsen disordered eating. A negative self-worth. Pre-existing feelings of worthlessness and poor body image from depression can drive disordered eating patterns to try to, quote, fix the perceived flaws. Now, if we turn back and look at eating disorders and the impact on depression, we can see how this can work in reverse as well. Malnourishment and starvation. Malnutrition and severe caloric restriction, such as we see in anorexia, can cause physical and chemical changes in the brain that can directly lead to mood changes and worsen depressive symptoms. They can also increase anxiety, as we saw on the slide before, irritability, and social withdrawal. If we look for a second at binging behavior, there's often a post-binge guilt. And for those who binge, the initial temporary relief is often followed by intense feelings of guilt, shame, and self-loathing, which can deepen depressive symptoms and feelings. If we turn to social isolation, eating disorders often involve secrecy and shame, causing individuals to isolate themselves from friends and family, which is a major risk factor for worsening depression. And the physical toll. The physical consequences themselves of eating disorders, including fatigue and health complications, can further decrease energy levels and contribute to feelings of hopelessness associated with depression. So all this leads to the obvious question of cause and effect and the age-old question of which comes first, the chicken or the egg. And there can be important implications for treatment in knowing which comes first, but either is possible. I've seen patients who, due to their eating disorders, have become depressed primarily due to malnourishment, but I've also seen patients who, through their depression, who had no body image concerns, develop eating disorders due to unintentional weight loss associated with their depression. And sometimes individuals can develop eating disorders as they are in the process of refeeding or gaining weight. The fact is, either way, once something is there, it deserves our attention, even if it arises secondary to another cause. So how do we break the cycle? Well, there's therapy, and there are several therapeutic strategies, such as cognitive behavioral therapy, or CBT, family-based therapy, and interpersonal psychotherapy, all of which have validation with one or more of the major eating disorders. But we need more validated treatments and more research in general. I'll also say exposure therapy, which is particularly relevant for anxiety, which is essentially gradually and safely exposing oneself to the feared situation to weaken the fear response, often with subsequently avoiding responses, such as we see in ARFID. But in essence, if one has a fear of food, all meals themselves become an exposure. Making a behavioral change. So eating regular meals and snacks in intervals on a healthy meal plan can overnight be a huge behavioral change. Medication. Prescribed drugs like SSRIs can help regulate neurotransmitter levels in the brain, but unfortunately medications in general have limited efficacy for anorexia, and one must watch for medical side effects, especially at low weights. They're often much better in treating the comorbid conditions, which often respond better. Nourishment. Food is the best antidepressant and often a very good anxiolytic as well. But it should be noted that the process of restoring to a healthy weight often leads to worsening body image, at least initially, and support must be provided for substantial periods after a healthy weight is achieved, as anxiety around issues related to body shape and size often persist for many months. It's not simply a matter of just eating more. If it was that simple, eating disorder programs and treatment centers would not exist, and I'd be happily looking for other work. A word about family involvement. Families are often blamed for eating disorders, where no blame is really deserved. And Judy Herman writes that recovery always occurs in the context of connections and relationships. And this is really true, especially for eating disorders, where families have the important role of being allies in the recovery process. And then lastly, mindfulness and relaxation, techniques such as deep breathing, progressive muscle relaxation, meditation, all can help the nervous system and regulate physical symptoms. So what is below the surface? We should recognize that what we see may just be the tip of the iceberg, and that understanding contributing factors is crucial. And with eating disorders, it's especially important to recognize what is under the surface and often unseen. Eating disorders most commonly emerge in adolescence or young adulthood, and we must be mindful of the many factors that can contribute to the development and maintenance of an eating disorder, such as trauma, abuse, neglect, teasing about weight, bullying, exclusion, teenage drama, school failure, school stress, learning difficulties, family discord, including divorces, moves, financial distress, illness, both personal and family illness, food insecurity, anxiety, depression, even substance abuse. In essence, many of the social elements that I mentioned earlier in the biosocial drivers of eating disorders. Eating disorders, anxiety, and depression all have the power to take us away from the most important and meaningful things in our life. And the goal in treatment is simply not to just feel better, which is important in its own right, but to return to the important things of meaning in our lives, such as employment, graduations, connections with families and friends, and if in the case of an adolescent, getting back onto a developmental track. We do see with anorexia nervosa that roughly 80% of people either have a full recovery or see some significant improvement. Another 20% will continue in a chronic state with anorexia, and important to note, 5% will have a mortality. I think it's important that I say a brief word about some of the myths of eating disorders. Sometimes people believe they only impact certain populations. Eating disorders do not only impact wealthy, cis, white women. Eating disorders impact folks of all colors, shapes, and sizes, and they impact people from all identities and from all socioeconomic statuses. Unfortunately, myths have power and they persist. And despite similar rates of eating disorders among white, Hispanic, Black, and Asian people in the United States, people of color are significantly less likely to receive help for their eating disorders. Similarly, people of color are also significantly less likely to seek help for an eating disorder. So where do we go from here? First, we need to have more research, both on treatment methods that are validated for eating disorders, looking at the comorbid anxiety and depression in particular, and then also psychopharmacology studies on medications that might be helpful in treating eating disorders. At present, there is a scarcity of studies on all areas of eating disorder research. An example is that for every 78 cents that we spend on eating disorder research, roughly $87 is spent on schizophrenia research. And these are roughly equivalent prevalencies. The editorial boards of JAMA, Psychiatry, and American Journal of Psychiatry don't include any eating disorder researchers. So we need more education, both to the general public and to clinicians, aimed at both increasing our understanding of and dispelling the myths and misinformation that surrounds eating disorders. We want to help individuals with more effective treatment earlier. We want to reduce stigma. We need to improve recognition and screening tools, and we need to continue to disseminate existing interventions. So in summarizing, I want to emphasize that eating disorders, although complex, are indeed treatable. And I want to close by thanking you for attending this webinar and for the opportunity to speak about this important topic. Thank you.